Coming on to the speaker, we're delighted that Professor Iain Hutchison could speak to us tonight. I heard him speak and was very impressed, and when we invited him and he accepted, and I looked on the internet and found that his abbreviated CV was 12 pages long, I thought, I need some help. So we're delighted that we were able to get someone with sufficient qualifications and very appetite to do the introduction. So on that note, can I ask Baroness Helena Kennedy, QC, to come forward.
What Brian hasn't told you is that, of course, I'm the wife of the speaker, and that my husband was asked who he would like to introduce him, and what possessed him, I don't know. He was taking a terrible risk. I should tell you that I am a criminal lawyer. Everybody should know a criminal lawyer. I think he'd been watching all of those political conventions in the United States where adoring wives, Mrs. Obama, Mrs. Romney, went onto the stage and looking adoringly said how fabulous their husbands were. Well, I did ask him, how much is it worth? Queen's Counsel don't come cheap. Was I to prosecute or defend? Prosecution would be very easy, let me tell you. The indictment would be long. Chronic lateness. If anybody knew my husband, they would know what that means. A capacity for blurting out the inappropriate, infuriating stubbornness, unapologetic and incapable of saying sorry, a total control freak. And those are the things that I can tell you about. So I say to him tonight, this is my opportunity to lay you bare, to pare back the skin, expose your underbelly, take a forensic scalpel to you and dissect your failings. But I could be nice to you. My husband is brave. Many who know him will tell you that he's prepared to go where others would not dare, as a surgeon and in other parts of his life too. But then I could take up the cudgels in his defense. I have defended lots of guilty people. Do I mitigate for him and explain that his heart is good and that he really is a decent person? Certainly I could tell you that his enthusiasm is boundless. So what can I say about my husband? Well, let me start by telling you that it would be hard to find a more committed doctor. He loves his profession. He is passionate about his profession. He loves it with every bone in his body, with every muscle, sinew, and fibre, and it's the real love of his life, and I come a very poor second. I know that medical wives all say that. He's a brilliant surgeon and has continued learning and exploring ways of improving what he does constantly. But he's a total alpha male. You know that, you men and women in the medical profession, that horrible syndrome of the alpha male. High speed, high performance, highly competitive. I remember once reading aloud a newspaper article to my husband, and it was about a surgeon who did a tracheostomy on an aeroplane. You know, one of those calls where they say, is there a doctor in the house? Is there a doctor on the plane? It was an emergency. He used a knife and a fork and a corkscrew and a straw, and Bob's your uncle, he saved a life. My husband must have been the only man in the world who was jealous. He snatched up the newspaper and tried to think of ways that he would have improved upon the whole process. He never lets up. He goes to battle for a patient and cares for them as if they belonged to him. They end up loving him with all their hearts, and he adores them. I don't know how many doctors have driven to the bowels of Essex because he felt he had to explain personally to the whole family whom he'd come to know and love why someone had died. He sat into the night with a dying patient and read him Alan Bennett's short stories, which the guy had said he was really inclined towards. He's brought woolen socks out of his own drawer because someone complained that their feet were cold, and has bought noggins of whiskey for people who do need some good cheer. He has cycled marathons and worked from the crack of dawn, organising and fundraising like a demon for the charity Saving Faces that he created, and created out of, in fact, the legacy that his own mother had left to him. He has turned that charity into an incredible research foundation working on improving surgery of the face, particularly when people have suffered terribly invasive cancers, trauma after gunshot wounds, awful childhood deformities. And he really is propelled by a desire to improve the science that's behind his work as a surgeon. His integrity is beyond question. He wrestles with ethical issues. Indeed, one of the stories with which we regale people is that he was speaking not very long ago in Spain, and I hadn't heard him speaking for a while, and he was on the platform and some questions started being asked, and someone asked about the ethics of somebody who would be treating someone like Michael Jackson. What would a surgeon feel if somebody came and said, you know, I'm a black man, but I want to look like a white man? Do you think that's ethically correct to do that? And Iain answered the question, and then it stimulated some thought in me, and so I put my hand up, and he looked rather quizzically. And a lot of the people were listening, of course, through earphones because it was in Spain. And so I said, I read recently of someone who had a Down syndrome child, and they wanted to have facial surgery on the child in order to, so that the child didn't look Down syndrome. Do you think that's an ethical thing to do? And Iain, because I've never asked him, Iain said, well, actually, I always remind myself, and I remind those whom I teach, that we are the doctors of the child. The child is our patient. And we must make sure that we're not doing things because it makes the parents feel better. And here I made a rather, I thought, interesting comment, which was that children were often, children like that were often saved by the fact that they looked different, because it meant that people were more protective, more able to understand, and more perhaps willing to do things for those children. And actually it was a signal that was a positive one rather than negative. But he then, when I raised my hand again to ask a supplementary, said, I'm going to sleep with you tonight. Why are you asking me this? Everybody in the audience turned around because they thought he was picking up a woman in the audience. And there were a few moments before he bothered, because he and I both roared with laughter. He explained that, in fact, he was married to me. The next woman who asked the question said, well, I'm not sleeping with you tonight, but I do want you to answer my question. I just want to tell you that I feel very lucky to be married to someone who's so committed to his work, because I think that when you know that what you do, as so many of you in this room know from your professional work, when you're making a difference to people's lives, when you really are creating that kind of change, when you're interacting with people at moments of extremis, where you really can do precious, precious work that can make them function well, can make them survive longer and without pain. What greater gift have you all got than that? And so I say, with admiration, with pride and pleasure, I'd like to introduce to you my husband, Professor Iain Hutchison.
The dangerous thing about asking my wife to introduce me is that she's the wittiest person I know, the greatest communicator, and after her, everything you're going to hear is all downhill. However, I did want to know how she felt about me, really, and I'm looking forward to an opportunity to introduce you sometime, Helena. My wife is a wonderful woman. Now, the key here is to get the... I don't want to... Do you want to find my my thing on the desktop for me? Thank you. Is that it? Can you end that presentation? Thank you. I'm having spoken about my wife, and I could spend the next 40 minutes talking about my wife and her great passion for her work and how we commune at night when we're both home, and have wonderful, I learn wonderful things from my wife. Occasionally, my wife has a little bit of help with her legal work from me. Pillow talk, we call it. But I'm here to deliver the Ronald Furlong lecture, and I'm absolutely delighted and honoured that you've invited me to do this, Brian. And presumably the trustees knew about it as well. I read a little bit about Ronald Furlong, and so I do want to say a few things about him. It seems like he was the first real European man. He was interested in German surgery. He was interested in the hand surgery in Italy. He achieved something that I wouldn't achieve. He got blessing from Pope Pius I can't remember which pope it was, but he got a blessing from the Pope. And he lived till he was 93 years old and operated until he was 88 years old. I'm going to be lucky to make it to 88, let alone operate at 88. He learnt his skills early on, but delivered them to people in the North African part of the Second World War, and obviously honed his skills and was a very prolific surgeon there. What was interesting was, and sometimes when I talk about surgeons, I like to show a little film clip of Lancelot Spratt from Doctor in the House. I don't know how many of you have ever seen that. If you haven't seen it, try and see it. It's a terrific view of how patients saw us at that time, and probably still see surgeons like that. And there is an element of the surgeon or of Lancelot Spratt in all surgeons still. But what's interesting is that Ronald Furlong was described as a tall, handsome man who was a bit of a showman, who was a brilliant teacher, not as well as a brilliant surgeon, and that Richard Gordon may well have modelled Lancelot Spratt on him. But I want to come on to the parallels. Ronald Furlong did something quite extraordinary. First of all, he opened his mind to Europe, and so although he'd been fighting against Germany in the war, he was very interested in the way the Germans were treating fractures. He went over to Germany, and he kind of introduced the concept. Charnley was the first person to introduce hip replacement surgery into the UK, I think. But he was using acrylic cement, denture material, to hold things in place. And Ronald looked at having uncemented hips and using hydroxyapatite. So that was a very innovative idea, and he set up a company as a result of that. His father had been a businessman. And what he did with that money was he set up a research foundation, the Furlong Research Foundation, which then became the Orthopaedic Research UK. And when he died, he bequeathed you, I think, 20 odd million pounds? No, I wasn't mentioned that. Wasn't it? Okay. All right, fine. A lot of money anyway. Yes. So here was a guy who was interested in innovation, who was interested in research, but also was generous, charitably generous with his money. So I'd like to think that I could be a little like him, because I have set up a research foundation. And the one thing I would say about my wife was my wife delivered a lecture. She was offered £5,000 to deliver this lecture, and that money she gave to, that was the first money that the Facial Surgery Research Foundation Saving Faces received. So it grew from that seedbed. But that was a very brave lecture. Well, it wasn't a lecture, it was an after-dinner speech in Edinburgh on the eve of the Calcutta Cup, with 5,000 men and 3 women in the audience, competing with not Gordon Brown, I can't remember his name, the second row forward who died of leukemia or lymphoma, and who was a brilliant speaker. So these two, Helena was competing in a male audience. They'd only recently invited women to sit in there. So she went into this bare pit of men and braved it to give £5,000 to the charity. That's what I'm talking about. But the key is, there are more questions than answers. There's a wonderful Jimmy Cliff song. I won't sing it for you. There's somebody nodding in the audience. Perhaps you'd sing it to us over dinner. Thank you very much. So let's look at this. How common is this? And yet look at the scars. We can't, people come to me and say, can you remove the scar, please? Well, we can't remove scars. We need to do research. Something as basic and as common as this, we don't have an answer to. I really enjoy showing this picture to people. It's Treacher-Collins syndrome. She's 10 years old. She's still got a tracheostomy in place. She's a UK citizen. So why has she not had any treatment for this? Why does she still have a tracheostomy in place at the age of 10 years when she could have had that removed by having surgery? The answer is because her parents are very intelligent. That is their problem. They have been to see... is there a problem, Roland? No? Great, okay. It's being filmed for your website, by the way. The problem is they've been to the 5 craniofacial centres in the UK. Glasgow, Liverpool, Birmingham, Oxford, London. Different answer in each case. They've been to New York, to McCarthy. They've been to Los Angeles, to Kawamoto. They've been to Tessier's successors. And everywhere they've gone, they've had a different answer. Now, all of those treatments are relatively successful, but which is the most successful? Nobody knows, because nobody's ever done a prospective randomized study comparing the different treatments. If we did an international study around the world, we could get the answers. You can't get it in England alone because the frequency of the disease is not that common. But we could get an answer to that. All the treatments are relatively successful, but the parents can't decide because they want their child to have the best treatment. And why wouldn't they want to have the best treatment? So they have chosen no treatment. They're rabbits in the headlights. The car is running down the road at them, and they're stuck in the middle of the road, and they don't know whether to go left or right. So they stay in the middle, and they'll run over, and their child has no operation. Why should we do surgical clinical research? You know, we do a good job. 20% of the time we do, it's only 20% of the time where we don't achieve best results. We do well. But it's vital, surgery is, for treating injuries, disfigurement and cancer. So, you know, that's where we should be doing the research. I've mentioned about that. And the key to doing prospective clinical research, ideally prospective randomized, is the results have an immediate impact on treatment worldwide, because you really only get 4 alternatives if you're comparing 2 treatments. Treatment A better than treatment B better than treatment A, both equal, or treatment A is better for diabetics over 50, treatment B is better for young, fit, healthy people. So you get answers straight away. We can do clinical research, surgical research on all these situations, starting from right at the beginning, the epidemiology of the disease, going through prevention, diagnosis, pre-treatment preparation, the actual treatment itself, adjunctive support, right round to end of life if we're dealing with cancer. All of those areas are areas which we can do research in. We can do translational research. So we've set up a tissue bank, and our tissue bank is all the patients are consented to have their clinical data compared to their tissue, so that we can look at the clinical outcomes compared to the tissue. We can look at and do material science, We can look and do some material science and tissue engineering with Lucy De Silvio. We can do psychological studies on orthognathic surgery, and we can do sociological studies on PDV. PDV is not a new virus. It is potential domestic violence. So it's not the new scourge of the world. It actually is the scourge of the world. But so we can do those kind of studies. Let's look at teenagers' attitudes. If we were to draw a line across the commissure of this woman's mouth, you'd say that she was a very attractive young woman, but she has a skeletal 3 relationship. She's got a lantern jaw. And what that means is that actually, in studies that we've done, we got photos of patients who had jaw surgery to put them into a more normal relationship. Before, we had photographs before the surgery and after the surgery, and the surgery was maybe 18 months apart, you know, the photos, they were wearing different clothes, and we mixed them up with normal people. And what happened was that they were clearly judged adversely, not just on their attractiveness beforehand, but on all these subjective things. Their attractiveness rose, great. Their honesty rose. They were more honest after the surgery. Their friendliness rose. They were less violent after the surgery. Their intelligence rose. Did all these things really happen to them? No. It's how their peers judged them. They were making snap judgments over 2 minutes on a profile and a full face. And they made judgments. We asked them to make judgments on all these subjective things. So quite clearly, these young people are actually being underestimated in their abilities, in their knowledge, and their skills because of the way they look. It's crazy that we make these judgments, but we do. Todorov tells us that in 1/10 of a second, we make a judgment on a person just on their facial appearance alone, you know, for their honesty, their friendliness, their violence, the whole lot. And these negative influences blight their opportunities. Imagine your peer group constantly saying these things to you from the age of 13 to 18. Your teacher's saying it to you. What does it do to you? We've also done a similar study on pediatric hemangioma and asked the parents to tell us how other adults treated their children, how other adults who were in the family, close relatives, treated the children, how other children treated the children with these hemangioma on their face. And what we found was that before and after the treatment, the child behaved differently because other children are coming up to them and actually sticking their finger in it. Because it's curious, isn't it? They're not frightened. The other children aren't frightened by these appearances. They're curious. This is an unusual thing. What does it feel like? Is it hard? Is it squishy? We'd like to do it as well, but we're constrained by our social upbringing. But a 2-year-old child isn't constrained and wants to do that. And so these children are constantly having people staring at them and maybe saying adverse comments, certainly other adults. After the treatment, bizarrely, some of the parents felt a grief reaction at the loss of their child. Their child looked normal again. But to them, their child was magnificent. And so it doesn't always work well for the parents immediately after the surgery. Let's look about prevention. We've had that on the list. The great scourges of the world are infections, tobacco, alcohol, and war. I'm not going to talk about war, but I'm going to talk about tobacco. So we've done studies on school children, 15-minute talk from a surgeon in a school, showing them pictures like this, telling them stories about this, saying this could be your granny if she chews tobacco or smokes. This is you if you smoke tobacco. You've had your jaw split, so we can take away your throat, right down to your voice box. We can take away your upper jaw, your soft palate, and you end up looking like this. Not bad, but look at that. You're not eating, you can't talk, you're breathing through a tube for the rest of your life. And so we say to the children in the room, if all of you smoke, one of you is going to die of a tobacco-related disease. Look at the person next to you. Is it them or is it me? Could it be this? And then we study them afterwards. At 3 months, 8 out of 10 remember the talk. Almost half of the smokers had quit. The knowledge that mouth cancer could be caused by smoking improved, doubled in knowledge. And over half the children spoke to their parents and said, don't smoke. Whatever you do, don't smoke, or don't chew. So this stayed with them for 3 months. At 30 months, bear in mind some of the children will have left the school, new children will have come in. We don't know about that. 50%, half remember the talk. A 15-minute talk in a school assembly, but by an expert, by a surgeon, somebody who has power, who has confidence, who can talk about this. A third of them, they said the talk stopped them from starting to smoke. We'd started, these were the 11 and 12 and 13-year-olds, followed through till they were 16. 1 in 10 said the talk stopped them smoking. That's the largest successful intervention that I know of in this field. But it had an overall effect on almost a half of those patients who remember the talk. Similar thing with binge drinking. Epidemiology, we've done 2 studies. The first study in 1998 was on a week. We went into every single accident in the emergency department, tried to pick up every single facial injury, the causes, where it happened, what time of day, what day of the week, what they were doing, what their socioeconomic group was. And what we found was the commonest serious facial injuries occurred in the 15 to 25 age group on Friday and Saturday nights associated with binge drinking. We projected 125,000 serious facial injuries a year in the UK through binge drinking. So we did a similar thing on binge drinking, going into schools and trying to discourage kids from binge drinking. We've now done a study on 8,000 school kids aged 13 and 14 in deprived areas. 4,000 have had the talk, 4,000 haven't had the talk. Nearly half of them had binge drunk in the previous 3 months. These are 13 and 14-year-olds. 8% of them had had sex that they later regretted. 13 and 14-year-olds. 25% of the boys had got into fights when they were drinking. Not a big deal. Doesn't take much to get a boy in a fight. But 18% of the girls had got into fights when they were drinking. So binge drinking was a serious problem amongst this group. When we followed them up, we found that, that they knew the harm that they could suffer, they suffered less harms, and their drinking habits changed in the 4,000 kids who had the talk compared to the 4,000 kids who didn't. So it was effective. We showed them pictures like this. The last picture we showed was this, saying this guy had his nose bitten off when he was 19 years old. He didn't have anything done about it. Well, he did. Somebody tried to implant the bitten off nose. It was spat out and he was on the road, and so they tried to reimplant it and it fell off. But he didn't have anything more done about it, and he became upset when his 5-year-old daughter wouldn't walk with him in the street because people pointed at him. So that's when he decided to have something done about it. We've got public information projects. Mouth Cancer Awareness Week. I've talked about the paediatric hemangioma. I'm not going to talk about the Saving Faces Art project. That would take another hour. So in 1994, I wrote an editorial in the British Medical Journal, which led to the first Mouth Cancer Awareness Week in 1995, led by the British Association of Oral and Maxillofacial Surgeons. And essentially, what I showed was that patients didn't know that cancer could occur in the mouth, that doctors didn't recognise, GPs didn't recognise cancer in the mouth, and that dentists didn't recognise it either. What we've done is we've done sequential follow-up on 448 dentists in London with a phone call. The phone call is from somebody who says, my dad is 57 years old, he's had an ulcer on his tongue for 4 weeks, it hasn't gone away, he's a smoker and drinker, he's tried Bonjela, he's tried mouthwash, it just hasn't worked, what can we do? And only half of the receptionists gave an urgent appointment. Some said, nothing to do with us, go and see your doctor, go to the pharmacist, use a mouthwash. Things have improved with the receptionists a bit, but not very much. The dentists now recognise things really well, but their receptionists don't. So we've got a campaign to deal with the receptionists. GPs, in the 100 patients that I saw that was part of the study that showed this, 100 consecutive patients, their mean delay, the GP's mean delay before they passed the patient on was 2 months. They gave repeated antibiotics, and 50% of the GPs delayed greater than a month. The other thing that we've done is we've run GP practices, and what happens is we tell exactly the same story, and there's a pause. And you can visualize the receptionist typing into the computer. You can see the practice nurse in 10 days. It's a new patient. You can see the practice nurse in 10 days. So they haven't heard the story at all. All they're doing is saying, you're a new patient, you've got to see the practice nurse before we'll take you on. That's a 10-day delay in a potential cancer patient. What did the patients know? Before 1995, a quarter of patients knew that cancer could occur in the mouth, and they delayed 3 months, their average delay, before they consulted a primary practitioner, not received at hospital, was 3 months. The longest delay was 12 months. Post-95, after the first mouth cancer awareness campaign, we doubled the knowledge, but still only 50%, and it's still less. Now, bear in mind, these were mainly men. They knew more of them knew about cervical cancer in women than they knew about mouth cancer. So cervical cancer in women was never going to affect them, but mouth cancer did, and they didn't know about it. But the delay had dropped thanks to that campaign. Then we have all sorts of things. We're now doing a football study because what we want to do is try and get people back out as quickly as possible. And the reason for that is, on the one hand, you can have people with fractured cheekbones who are treated and out playing again in 3 days, and then you have somebody like Ryan Giggs who has a fractured cheekbone and he's kept off play for 6 weeks. Why is that? So we've tried to do a football association study. They're not particularly helpful, but we've succeeded in garnering last season about 60 injuries, and we'll publish on those and hope that we'll get more knowledge and improve as time goes on. We are excellent at innovation. There is absolutely no doubt about it. Ronald Furlong and many, many others. But we're poor at evaluation. So here we are innovating. This is a guy who's got a sarcoma. He's lost the whole of the left-hand side of his jaw. He's lost his maxilla. He's lost all the soft tissues of his face out to the skin flap with the facial nerve underneath the skin flap. So he's lost his parotid, he's lost all that type of stuff, and some of his throat too. He's had a pre-bent plate using 3D CAD-CAM planning, and on the model we've pre-bent a plate so that we know that we're getting the microvascular reconstruction in the right place. That's done at Cavendish Imaging up the road with one of my former trainees, Andrew Darwood, who has been working with several orthopaedic surgeons on doing the same kind of thing on hip replacements. So maybe he should be bidding to you for money. What the patient said to us was, hang on a moment, I'm having chemotherapy for this. Are you okay, sweetie?
No, I'm fine. I still like looking at the bloody pictures.
Okay, fine. The other thing was that the patient said to us, look, I'm having chemotherapy all this time. What are you going to do about it? What about teeth? So Andrew planned to put implants in, and on the operating table, the patient not only had the reconstruction, but also had the implants put in, and he had a bridge fitted straight away. So when the patient woke up, and this is him a bit later, when the patient woke up on the intensive care unit a week later, sorry, not a week later, a day later, he didn't say, my shoulder hurts where you've done the subscapular axis microvascular free flap with the skin and the bone. He said, my teeth don't meet perfectly. You know, like he just had an amalgam filling or something like that. Anyway, so then we have, so this is a little bit of innovation. This is a guy who had his face shot off in Nigeria, flown over for treatment, lost his lower lip, lost his jaw from angle to angle, lost some of his tongue and his floor of mouth, also had bullet wounds in his arm. He was a bank manager, and his wife helpfully gave us this picture and said, can you make him look like that? So within 2 operations, we make him look like that. The first operation was the main bulk of the reconstruction. The second operation was essentially doing what's called a carapandage flap. So initially he had latissimus dorsi muscle and scapular skin there, and the latissimus dorsi muscle reconstructed his lip. But he had the teeth fitted at exactly the same time, and the implants put in his scapula at exactly the same time. So he woke up with his jaw reconstructed with implants in the scapular bone and the teeth, and then a second smaller operation just to move the upper lip round to the lower lip so that he had a more normal looking lip. What are our levels of evidence? Well, we have, this is the kind of standard thing, but this is what we'd like to have, randomized control trials, but we're really mainly good at doing cohort studies. That's the best we normally achieve. Most of us are case reports, case series, case control studies. So the juniors amongst you will be familiar with the consultant surgeon saying, I want to look at this new hip implant that I've been using. Will you go and find the notes? Go down to the bowels of the hospital. The notes are usually kept in the basement of the hospital, and there are cockroaches crawling around the floor. There are a few mice and rats nibbling at the notes, so you might not see them particularly well. And then you bring the notes up and you show the consultant says, no, don't include that one. That one's a bit fat and old. And the junior says, this one, the notes are incomplete. And the consultant says, no, include that one, because it's got good results. So the point is, there are all sorts of bias in what we do. But these are the 2 things that I want to focus on the end of the talk. Because surgeons say to me, I won't change my practice unless there's a prospective randomized study. But they won't do a prospective randomized study to demonstrate the difference. We'll talk about that in a moment. Those are the reasons why a prospective randomized study is so valuable, but we've got a problem with prospective randomized studies. So can we do them? Why don't we do them? What are the risks if we don't do them? The problem is, surgery is not medicine. It is an irreversible act that causes harm by definition. Now, I don't know whether you remember the first time you cut into somebody's flesh. The poor consultant who was assisting me doing an appendix stood there for 15 minutes while I was cutting air to begin with and then stroking the skin. I didn't draw blood for 15 minutes, I'm sure. It's a terrifying thing that we do. So we cause harm. And what we have to do is be confident enough to know that the harm we're doing is outweighed magnificently, magically, hugely by the good we do. So we have to be confident. And of course, we're expected to reproduce the same outcome with each operation. So our patients expect us to be confident. They expect us to be decisive. They don't want a surgeon saying, on the one hand, I could do this, and I've just read about a new operation in the Orthopaedic journals, and that's an interesting thing, and my mate just around the corner is doing a very interesting thing, we could do that. They want a metaphorical arm around the shoulders, say, I know how to make you better, and I'm going to make you better. That's what they want. That's what we want. I'm a patient too. Hands up, who's been a patient? So it's very important to remember when you're treating patients just exactly what you felt like when you were being treated. How helpless you felt, maybe. The power leaches away from you when you're a patient. Look at this list. Those are the reasons why surgeons don't do it. We're so busy. We've got so much to do. We don't have the skills for trial design, statistics, project grant bids, ethical approval. There are lots of reasons why we don't do it. That's not the reason. The Facial Surgery Research Foundation solves all of that. That's not the problem. This is the problem. Philosophy. Philosophy. We've got to believe that what we do is correct. So doing a prospective randomized study is anathema to us. We have to, if we're going to do, we can't do prospective randomized studies on our own. We have to do multi-center studies. That means we have to collaborate with others. But they're not as good as us. We know they're not as good as us. So why should we collaborate with them? And then we've got to talk about the standardization of treatment, and then we get into the intellectual arguments. Well, for me, it's the neck dissection. What do you mean by a level 1 to 4 neck dissection? Does that mean you go 2 centimeters behind the internal jugular vein, or do you go on the edge of the internal jugular vein? Everybody interprets it differently. And then you've got the pathology reports if you're dealing with cancer. My pathologist does 125 micron sections. They're really good. Your pathologist just cuts a node in half and just looks at it and doesn't even look under the microscope and says, oh, there's no tumour here, throws it in the bin. The point is that we're all, we deride each other. We're not good at collaborating. Then we've got the difficulty of presenting the study to the patients. I've learned a huge amount with the elective neck dissection study that we started, which is the most important study. But in this country, it's only recruited 200 patients. That's more, that's 3 times more than anywhere else that it's been done. But, it's only 200 patients. It needs to get up to 650. And it's been going for 4 years. And over that time, there have probably been 1,000 patients that were eligible that just weren't recruited. The surgeon said, well, T1 is 0 to 2, T2 is 2 to 4. At an MDT, you have to stage it. You say it's T1 or T2. But the surgeons say, no, if it's less than 1 centimetre, I don't really want to do a neck dissection. If it's over 3 centimetres, I really want to open the neck because I want to do a microvascular free flap reconstruction because I think the patient's quality of life will be so poor if they don't have the microvascular free flap reconstruction. So we say, okay, we'll do 1 to 3 centimetres. So then I say to the surgeons, when I find they're not recruiting patients, I say, how are you measuring the primaries? Oh, I just look at it, or I feel it with my fingers, and my fingers are 1 centimetre wide, so that's 3 centimetres. How wide are my fingers? Anybody want to hazard a guess? Oh, underestimate. 17 millimetres. 17 millimetres, okay? So the point is that we intellectualise and say 1 to 3 centimetres, and then we don't bother to measure it. And then we had this ridiculous thing of the late contact with the research nurses saying, so they say to the patient, well, I would normally do this, but we're in this prospective randomised study, so I have to enter my patients in the study. So by the time the research nurse gets there, the patient says, I know what the right treatment is. The surgeon's told me, I'm not going in this study. I just want that treatment. So, we learnt a huge amount from it. How to improve surgeon involvement. Now, the key is, and this relates back to my wife, because my wife thinks prospective randomized studies are dreadful. Okay? She said to me, I want to look into the eye of my surgeon and trust them. I'm going to judge them. I'm looking at Brian at the moment. Do I trust Brian? Do I trust Lucy? No, Lucy, your eyes, no. So the point is, you've got to be a good salesman if you're going to convince my wife to have surgery with you. She doesn't know how good you are as a surgeon. She assumes you're good if you're working at St Thomas's. She assumes you're not so good if you work with Barts. And the point is that that's not a way to find results. So I see patients all the time who are confused because they don't know what is the best treatment. So if we accept the fact that patients actually have been very happy to endo-stent, it's the surgeons that are the problem. If we accept the fact that it is really ethically and morally difficult for the surgeons to engage with prospective randomized studies, why not think about prospective cohort studies? These are the problems. We learn as apprentices to surgical masters. I've talked about irreversible act, and that leads on to the half of patients receive treatment that we wouldn't normally recommend. We have ethical and moral issues, and we're buoyed up by the fact that all surgical treatments are relatively successful. Now, I want to ask you in the room, and a lot of you will have had general surgery training, and so you'll know that an inguinal hernia, varicose veins, and hemorrhoids are the three big bugbears in general surgery. Tell me, anybody want to hazard a guess, how many centres in the world know the outcomes of their inguinal hernia treatment? Anybody hazard a guess? No? Very close. One. It's the Shouldice Clinic in Canada, because they only accept patients who are prepared to be phoned on an annual basis to find out the results of their treatment and to return if need be for treatment. Okay? So if you've got to find the results of treatment, you've got to follow patients for a long time, and you've got to have the patient's collaboration with that. So we end up with unsatisfactory surgical literature. I've talked about the disadvantages of multi-centre studies, but we have to be able to do them because there are great advantages. So we've ended up with this solution, the National Facial and Oral Research Centre, which is funded and controlled by UK Oral and Maxillofacial Surgery, but now also the British Oculoplastic Surgeons and the Academy of British Cosmetic Practice. It's funded totally by the Facial Surgery Research Foundation as a pump priming exercise for 4 years, but obviously it has to have successful project grant bids. I've recently been lecturing in Australia and the USA, and they want to use it. And the problem I've had is not with anybody else, but with my own organisation. Not my own organisation. My own organisation, British Association of Oral and Maxillofacials, have given it its imprimatur. It's the individual surgeon saying, why should we do this? What's the benefit? What's the benefit? I've got to find ways of making the surgeons feel that they're getting benefit out of it. It is the UK's clinical trials unit for head and neck. It will be the UK's holder of national data sets. The 10-year aim is that every single patient who is treated by a UK oral and maxillofacial surgeon will be on a data set, in other words, a prospective study with consent to long-term follow-up. So we can go back and ask them their outcomes later on. These are all our partners, the Health and Social Care Information Centre in Leeds. I've talked about the Academy of British Cosmetic Practice and the others, and the aim is to do prospective and prospective randomised studies. You'll recognise at the top there our Research Advisory Board, Paul Gregg, who's been incredibly helpful. You may recognise some of the other people like Serene Kennedy. Wally Gilbert is a biologist from Harvard, a Nobel laureate. Lewis Walpert was chair for the Committee for the Understanding of Science, Public Understanding of Science, and he's a patient representative. Ben Page is the chief executive of Ipsos Mori, that was on Radio 4 Today programme this morning, I think. So we've put together a good team to advise us. And what we're looking at is national audits or registers, which are effectively prospective cohort studies. And we've got lots of people who've been doing this and who've given me a great deal of advice and help. I just want to put at the top, the large data set is based on surgeon preference with this. So the surgeons can do what they want to do. But because it's such a large data set, we can compare the outcomes between different treatment protocols and determine best treatment practice in a large cohort study without the need for a prospective randomized study. The costs are relatively minimal, £500,000 a year for 400,000 patients under study per year. And we will educate the next generation in research by conducting special study modules in clinical research in medical and dental schools around the country. We'll have subspecialty groups in all the surgical organisations that will meet once a year, In the morning, they'll be taught clinical research methodology. In the afternoon, they brainstorm on research ideas that they bring along and do 5-minute presentations on, vote on them, and they go to the NFORCE Research Advisory Board to see whether they're a runner. The model is data collection, patient consent to long-term follow-up. We're only going to get people to complete the minimum data set if it really is a minimum data set, not something that goes on and on and on forever. And surgeons and their nurses are the best data collectors. We've got to have security of data transfer. That's why we're linked into the Health and Social Care Information Centre. And we want identifiable data allowing long-term follow-up. We ideally want the patients to enter their own outcome measures. That saves time and effort, but it's also more objective. Everybody's an equal stakeholder. That's the key. So if you enter data, you've got ownership of your own data, and you can access the data collected to look to revalidation on the national data set. But then you can also bid to look at the whole data set for that disease process and do research on it. So in the future, it can be mined by people to do PhD theses and the like on clinical outcomes. We'll fund local data collectors, and we have our research advisory board. The advantages to patients are eliminating confusion by providing evidence on different treatment protocols. Okay. The advantages to consultants, it is not for comparison of surgeons. I've talked to Paul Gregg about this. He had a major debate on the National Joint Register with a chair, which is why he's now the acting chair. I think he's still the acting chair, isn't he? Because the chair resigned, it was a lay chair, and he wanted to let everybody have access to it. And he said no, and he's right to say no, because the surgeons won't enter their data if they think that people are going to peer over their shoulder at it. They can use it for revalidation, correct faulty hospital episode statistics, use it for their studies, etc. Lots and lots of advantages to them. Advantages to the specialty, demonstrate treatment benefit, especially in things that we come across, interventions of limited benefit. I've just written my president's newsletter, and I've written 7 reviews that have been conducted. The Northern Ireland Review of Hospital Dental Services, the Cosmetic Review, the GMC are doing a review of oral and maxillofacial surgery. You know, it goes on and on and on. We need to have evidence to demonstrate benefit of what we do. Obviously, the governments are going to get a lot of benefit, and departments of health learning about the geography and epidemiology of facial disease. Will patients consent? We did a study. The problem, as you can see, is the percentage of patients approached by the surgeon. I'm too busy in the trauma clinic, I don't have time to get the consent from the patient. The patient read it in the waiting room, read the information leaflet in the waiting room, they saw the poster there, they read the information leaflet in the waiting room. All it took was the surgeon to say, have you read the information leaflet? Yes, no. If you read the information leaflet, are you happy to sign the consent form? Yes, no. That's it. Doesn't take a moment. But, you know, training surgeons to do anything other than they're paid to do is difficult. Oncology, 96% of patients agreed. Trauma, 87% of patients agreed. Dentoalveolar, 3/4. Orthognathic, 85%. The patients all agreed. The problem isn't the patients, the problem's the surgeons. Okay. So, what I'm saying to the juniors is, this is the way you get your PhD. You don't stop you're a surgeon, you want to do surgery. You don't want to go into the laboratory, you don't want to spend time doing this. You want to be in the clinic treating patients. So on your day off a week, this is how you plan your year, your 5-6 years, so you end up with a PhD and still manage to do work. Academics will allow you to get all the research accreditation that you need, the grant income and so on. All we want is, with every grant, we want you to put in for a data manager and a trial coordinator, which we'll have. So, I'm coming to the end now. The 21st century surgeon. We've got to embrace uncertainty. That's what the professor at Andrew Curry said at the interviews that we conducted. He mentioned uncertainty. We've got to embrace uncertainty. We've got to constantly question our teachers and ourselves, because actually the facts that we think we know are not facts. They're facts. And from those facts, we make educated assumptions. And those assumptions are perfectly reasonable. And I'll tell you an assumption. We know that 20% of patients have occult cancer in their neck nodes that can't be picked up on radiology. It's a reasonable assumption to say all those are going to go on to get overt lymph node metastases later. No, only 14% do. It's a reasonable assumption to make that if we operate when they're occult and small, we'll improve survival figures. No. If you operate when they've got an overt neck node, they get an 80% survival. So all those assumptions aren't quite right. So we've got facts, we make assumptions, we end up with hypotheses. We don't end up with facts. So question. The future is clinical research. And that's us. Our mission is to improve patient care and treatment through prospective registration and randomized studies. Thank you very much for inviting me. It's our legacy for the future. I'd be delighted to take questions, if people want to.
Does anybody have any questions? After that, yes?
Last question. That is, the rare and ethically and surgically challenging techniques such as face transplants, how do you as a surgeon, without any evidence, decide that it's doable or is warranted?
Right. Well, I've written extensively about that, and I feel that sometimes they're being done not necessarily for the patients, but for the surgeons. But you know, it's a plunge into the future, and as long as the patient is prepared to go with you on these kind of things, the key is, you know, I'm sure that the surgeon is saying to the patient, look, we can do conventional reconstruction, it'll leave you looking and show them patients what it'll look like. How do you feel about if we would do a face transplant? You're going to have immunosuppressive drugs. This will increase your risk of getting cancer later on, of having bad skin, having infections all the time. You know, tell the patients that. I think 3 of the patients who've had face transplants have now died. So there's a risk of death with any new treatment. How many patients died with the first heart transplants? I mean, I think all of Christian Barnard's patients died, the first 4. So, you know, you talk to the patients. But the face transplant is a different thing than the heart transplant because the patient dies without the heart transplant. The face transplant, as a psychiatrist put it, is converting a healthy person with an abnormal face into an unhealthy person with a more normal looking face. So there are huge ethical issues, and of course we in this country went through this in the Royal College of Surgeons, looked at it, and actually Peter Butler is applauded, although he's never done any face transplants, by all the face transplant surgeons, because what he did do was he set the ethical framework for doing it, which allowed the French surgeons to do it first of all. So when you hear Jean-Paul Menengo and Bernard Devonshire talk, they give credit to him for setting out the ethical framework by which it could be done. I don't know whether that's answered your question. It was quite a complicated question and requires quite a complicated answer, but if you want to talk about it afterwards, I'm happy to do that.
Anybody else?
I've seen among all your pictures, obviously devastating conditions for the patient. Of all of them, I've seen, in terms of biomaterials, only dental implants and possibly metal plate. Anything wrong with biomaterials?
I think the best reconstruction is the patient's own tissue, but the patient's own tissue might be the patient's own stem cells. And using materials that will form a framework, using a CAD-CAM thing, that will resolve with time, the body will resolve with time, but will act as a matrix for the stem cells to grow bone and to grow tissue in situ. Not in the laboratory, but in situ. We've had success with growing bones outside the area where they're meant to be. So the first report of that was from Kiel, from I've forgotten his name now, in the early 2000s, 2004, it was in the Lancet. And what they did was they had a patient who'd lost half of the mandible, and they grew it in her back under the systemus dorsi. They actually took bone chips from the iliac crest, put in bone morphogenetic protein and stem cells. But you know, it's difficult to tease out, was it the bone chips that caused the growth, was it the bone morphogenetic protein. But maybe Lucy De Silvio would be better answering that. But I think there is definitely a place for biomaterials, but using biomaterials as substitutes, permanent substitutes, I'm not comfortable with. Except in my own hip.
Do we have any more questions? No.
I'd like some stem cells for my knee. My knee's needed, yes. Okay.
Can I ask Mr. Vines to set up, please?